Good morning. Thank you so much for the invitation to be part of your meeting. I so wish that we could be together. We're all improvising. I'm so impressed with the adaptations that the conference organizers have demonstrated. The most important thing is that we are safe and that we continue to adapt. Um, so I want to start by sharing some of my disclosures. I am a faculty member at the Brown School at Washington University in St. Louis. My work is funded by the National Institute of Mental Health. This morning, I'm going to talk a little bit about, first of all, the imperative, the need for implementation science in all of our fields. I'm going to focus my remarks on the principles of implementation science, and then I'm going to end with some of the priorities for this field, with the challenges and opportunities for advancing the field. Implementation science is driven by the imperative to improve care. We know from a number of reports that the quality of healthcare in the United States across almost all areas evidences really wide variation, and there's huge room for improvement. Um, I am a big fan of the ARC quality recent that have been published, are the 2018 reports, and I'm going to spend a little time situating the imperative for implementation science in some of these reports. These reports are available by different priority areas, and they show us whether quality is improving, staying the same, or changing. And these are some of the areas that you can see. We also know that besides the area of health care, the overall quality of care varies regionally, and it varies tremendously. Your states, Rhode Island and Boston, are really in the highest quartile of quality of care. In Missouri, where St. Louis is located, we're in the second quartile. And we see that there are a number of states that are really faring quite poorly in terms of quality of care. Now, many of you have different interests in the areas of rehabilitation, and I've drawn just a few examples of figures that graph the quality of healthcare vis-a-vis what have been identified as achievable benchmarks. In this case, this slide represents the quality of home healthcare provider checking medications among people in home care. And the benchmark that has been set as achievable is 86%. And we see that across the board, we're not meeting that benchmark. In fact, from 2012 to 2017, there's been no improvement. I doubt that this decline is statistically significant, but we see that we're really not doing very well. Similarly, with home healthcare patients who had an emergency department visit and then were hospitalized, we see that, and this would indicate, of course, whether emergency room visits are not necessary. But we're seeing again that we're falling short of this benchmark. And in the area of preventive care, women receiving a PAP test in the past 3 years, we see that the achievable benchmark is 87%, and we're not reaching that. We're, in fact, we've declined somewhat. Now, a significant area of variation beyond type of healthcare and region of our country is, of course, disparity that is not driven by need, but rather is driven by demographic factors. And these bar charts, one for each underrepresented minority group, with Blacks on the left and Hispanic on the far right, we see three chunks of bar graphs, and we see the indicators where care has improved. We see the percentage and number of quality indicators that has stayed the same. And in red, we see that there are a number of quality indicators that have actually worsened um, for these groups. So we have a long way to go, both in geographical variation, in variation across type of healthcare, and variation in racial and ethnic disparities. In the area where I do work in behavioral health, we have some really alarming numbers that more than half of people who need mental health services are getting no treatment. And there are a variety of reasons for that. Often people cannot afford, they feel they do not have the time, they don't know where to go for treatment, or they feel that they can handle it on their own, which of course reflects a lot of stigma, a lot of misattribution of the belief that people can just pull themselves out of behavioral health problems. The Institute of Medicine has continuously reminded us that there is a huge gap, as illustrated with these graphs that I've shared with you, I hope, that there's a contrast between the care that could be if we were delivering evidence-based care and the care that actually is. And the last report that was issued really focuses on psychosocial interventions. And I know that many of you are involved in the delivery of interventions that require patient education or behavior change. And that report has, while it was focused on behavioral health conditions, the committee deliberately defined psychosocial interventions broadly so that a number of health behaviors were also addressed in that report. So again, implementation science is really all about how to improve the delivery of evidence-based care in real-world settings. So this is both the imperative, and this is the key principle for implementation science. The National Institutes of Health has, for a number of years, issued and reissued a program announcement inviting applications, research applications, to conduct research on dissemination and implementation research in health. And this screenshot shows the number of institutes and centers within the NIH that have signed on. And what this means is there's a common request for applications, and then 20 to 21 institutes and centers who will be eager to review and support high quality applications in this area. So this program announcement defines implementation research as the scientific study of the use of strategies to adopt and integrate evidence-based interventions into clinical and community settings to improve outcomes and to benefit our populations. I've always loved the clearer and more compelling definition of implementation science that I heard Carolyn Clancy, who was former director of ARC, now with the VA. Dr. Clancy defined implementation science in a talk that I heard her give as making the right thing to do the easy thing to do. And we know, of course, that a number of disciplines and fields are striving to improve healthcare. And David Chambers, who is Deputy Director of Implementation Science at the National Cancer Institute, has often used this slide, which he shared with me, and I'm sure many of you may have seen this before, that shows that implementation science really falls within the large circle or tent of health services research, and that there are many other closely related fields of health services that are also sharing some of the common goals and principles of implementation research. And of course, implementation research is also described as a phase of translational medicine or translational healthcare research. And the National Research Council, over a decade ago, highlighted some of the distinctions between different phases of clinical research. Pre-intervention research really helps us figure out what should we be targeting? What are the disease mechanisms? What are the improvement mechanisms? What are the behavior change mechanisms? Then in clinical research, efficacy and effectiveness studies, we begin to test what could we be delivering to address those targets? What interventions are effective and can make a difference and actually change those targets? Dissemination and implementation research address a different question beyond what to target and what to deliver. D&I research asks the question, how? How do we deliver those interventions? How do we help get them adopted? And how do we help systems of care sustain them over time and deliver them? Now, I am a big believer that everyone who is in healthcare settings wants to do the right thing, in Dr. Clancy's terms, but a lot gets in the way. And the first era of implementation research has helped us identify many of those barriers and facilitators. We know that resources get in the way, habits, even habits in the way we deliver care, rigidity, both within people, providers, and patients, and also within health systems. We're seeing in this era of COVID-19 a great deal of challenge in changing the way we do business. We're all saying, is this the new normal? And we'd like to revert to the old normal. So we see some inertia. We see lack of knowledge. We see fears about liability. We see issues of awareness. So even before we really know what we should be doing besides shelter in place or practice social distancing and good hygiene, we are really challenged to think what gets in the way of us changing in response to a health crisis or the need to begin to deliver new interventions. So, implementation science is known for having lots of frameworks, and I want to briefly continue my contrast between implementation science and some other fields of inquiry with this particular model that our team published in 2009. So, we're very familiar with the notion that the what we should be delivering is an evidence-based intervention. And we are interested in delivering those interventions because we believe it will improve outcomes. It will improve clinical status, health behavior, patient satisfaction. There will be good patient outcomes from evidence-based interventions. And our usual models of research to test the effectiveness of evidence-based intervention examines the link between these two components, the evidence-based interventions and the outcomes. Implementation science, however, we like to complicate things. We like to bring more pieces to the equation or to the analysis of how we need to do research and how we need to change practice. So in addition to the what, we're very focused on the how, which are the implementation strategies. We're also interested in proximal outcomes, and I'll elaborate a bit on that in a moment. But in addition to what we call distal patient outcomes, we're interested in, are these evidence-based practices feasible for people to deliver? Are they delivered with fidelity? Do they penetrate populations and health systems so that we're not just getting a tiny slice of people getting best care, but everyone is getting better care? Are new evidence-based interventions acceptable? Can they be sustained? And we look at all of these issues within the context of the health delivery system and the social context of people's lives, communities, and our social policies. So the core of implementation science is really these intermediary factors that determine whether the evidence-based interventions are going to achieve the patient outcomes that we believe that they will. So I'm going to turn now to a few of the key principles of implementation science. For several of these topics, you have additional sessions in over the 2 days of this conference, and you will hear more from other speakers about some of these topics. So the first principle of implementation science is that we really have to measure the quality gap. We have to know the difference between the care that is and the care that could be. And a first step toward mapping the quality gap is really measuring the services that are provided. So I've set the stage for this with the ARC graphs and the data about poor services or quality of care, the wide variation. We would not be able to have these reports from ARC if we weren't measuring who's getting what care. Now, a challenge is that data in many agencies and data in many electronic health records isn't really adequate. It doesn't capture quality. There are many practices that are delivered that are not measured in a standardized way. And certainly psychosocial interventions and the area of healthcare that I focus most on, we do have a long way to go in terms of developing standardized, reliable codes and measures of the services that are provided. So how do we know what the quality of care is? If I were to, I showed you an earlier slide that in behavioral health care, 57% of people are receiving any service. Now, that didn't even capture the evidence-based care that is being delivered. So in implementation science, we go beyond access and we look at the number of people receiving evidence-based care over the total service recipients. And this is what we saw used in the ARC reports, having a PAP test for women in a certain age. That is an evidence-based care. So our numerator is always the number of people receiving evidence-based care. The first equation here uses as the denominator the total service recipients. That would tell us the quality of care in a particular agency, in a particular health system, in a particular clinic, or serviced by a particular provider. A more ambitious definition or equation of quality would use a different denominator and look at the total number of people needing service who perhaps have not yet made it into the system of care. So we really have to measure the quality of care as a foundation in implementation science. And here are some additional, an additional source of national healthcare quality and disparities reports, and a bit more detail on some of the measures. I pulled some in areas where I believe that you, participants in this conference, would be practicing. And some of the measures that are far from benchmarks are long-term nursing home patients experiencing falls with a major injury. Measures that achieved the benchmark or have even exceeded it. Home healthcare patients with pain that when they move around on the decrease. So we're achieving that. That's kind of stated with a number of constructs, but it means we're reducing pain among people during their mobility. We're getting better at that. Patient-centered care has become another important hallmark of quality care, and the number of adults, the percentage of adults who report that their home health care providers treat them with courtesy and respect, we're also getting better. That's really remarkable. That's 95%. These are some of the ways that we track the quality of care. Now, the second key principle in implementation science is to select an intervention that can improve care or reduce the quality gap. So we need evidence-based interventions to be implemented. Where do we find those? And how do we assess whether they are appropriate for the setting? How do we find ones with strong evidence to improve outcomes? How do we find interventions that are ready for implementation and that meet the demand among agencies? Well, that's a tall order. So let's unpack this a bit. There are a number of repositories of reviews of evidence. The Cochrane Collaboration, of course, is a standard setting. Guidelines Central has a page devoted to rehabilitation. The ARC Clinical Guidelines and Recommendations, again, another page, and the ARC website has guidelines and recommendations in the area of prevention. The U.S. Preventive Services Task Force has both clinical and community guides. So these are a number of sources for evidence reviews to help us identify evidence-based practices that are candidates for implementation. This is a screenshot of Guideline Central for rehabilitation. There are guidelines for stroke rehabilitation, pulmonary rehabilitation. This is a searchable website, readily available, open access, as is the CDC's page on evidence-based interventions for quality improvement. And the American or the Academy of Medical and Surgical Nurses has pages on what is an evidence-based practice, what are some of the website resources. The third principle is one of the topics that your other presenters are going to provide you with more detail, and that is to assess context and engage stakeholders. Now, you may remember that in that figure of a conceptual model that I presented, there was a rectangular box surrounding it all labeled context. And we have a saying in implementation science that it is all about context, which is one of the tensions in our field because we are a science and we're looking for generalizable knowledge. And yet we often paraphrase Tip O'Neill, a famous politician who once said, "All politics is local." And we know that all implementation is local, even though we are striving to implement in particular settings, unique contexts, interventions that have been shown to be generally effective. So again, a challenge, a tension for our field, but nonetheless, we really have to be focused on context. I believe that every setting, every service delivery setting has implemented something. If they're serving clients, they have implemented. So it's important to reflect, what is the setting's experience with change? Have they been successful in adopting new practices at other times? How do people respond to the opportunity to improve care? What else is going on in the setting? Right now, we see that every healthcare setting is, it's not only stressed, it's in upheaval. Hospitals are not performing elective procedures. They are all about COVID-19. Community health settings are both swamped and going broke because they're not seeing patients. Something that is definitely going on in all of our settings is an underlying, probably epidemic of trauma and stress that will be surfacing sooner, if not later. So we can think about the context and how much this particular pandemic has produced upheaval in context and changed the realities for every single stakeholder. In implementation science, we always ask, who wants to improve services and why? Is there a demand? Is someone saying, you must do this? A policy. Right now, we're seeing states and different governmental units say, do this. And we're seeing a whole range of reactions, as we would expect when people are told to do something, when there is a demand. Is implementation being driven by a push out? There is something new that we could be pushing out. I think when there is a vaccine, there will be an attempt to push this out. We see influenza vaccine push out every fall. However, is there a pull? My infectious disease colleagues tell me that the only vaccine that everyone wants is the one that isn't available. So once we have a COVID-19 vaccine, will we see a pull? Will we see people demanding it? And then finally, a really critical consideration in the area of context is there infrastructure to deliver the care that we need? And we saw a chasm of infrastructure with the lack of personal protective equipment, PPE. We simply did not have the supplies to respond to this particular epidemic. Epidemic or not, crisis or not, these are important considerations in implementation science to think what is the context and who are the stakeholders? Who are the people invested in care who really want to be a party to the change? These are often service users, patients or clients, families who want the best for their families, individual providers, administrators who are faced with incredible decisions about how do they allocate scarce resources, funders who have to not only come up with funding, but often have a major role in allocating. We see bids, we see preferred formularies, differential reimbursement depending on what is paid or what is delivered. And we see a lot of government agencies and officials. So I know that Dr. Elwey's going to talk more about stakeholders. It is stakeholder analysis and contextual assessment is a key fundamental principle of implementation science. And we need to anticipate how will these folks react to change. A fourth principle is planning for change. We know that change is a process. Implementation science has actually a proliferation of conceptual models and theoretical frameworks. And one of the reasons that this is important is, again, that generalizable knowledge that we're seeking to develop. We're not looking for ad hoc, idiosyncratic change. We're building a science, and we can best do that. We must do that by positing our plans, our predictions on the basis of some framework, some theoretical framework, and then testing the robustness of those frameworks. Our research is designed to test whether the relationships that are posited in a given model or framework actually hold. And in a practical sense, a plan for change that derives from a model tells us what to do when. So planning and frameworks are critical principles of implementation science. My colleague Rachel Tubak published one of the seminal studies reviewing D&I frameworks and has a website where she has reviewed those frameworks. It's searchable. You can search for any different kinds of applications and whether they focus on dissemination or implementation. Uh, and many of those frameworks help us with the fifth principle, which is figuring out the how or the implementation strategy. And increasingly, we're seeing implementation strategies, fortunately, being aligned with and driven by our theories and frameworks. So implementation strategies are really another kind of intervention. They're not the what intervention, but they're the how intervention. How do we adopt and integrate evidence-based healthcare into usual care? And these are the active ingredients in quality improvement and evidence-based practice. Um, they are really the how component in Dr. Clancy's phrase, how to make the right thing the easy thing to do. The role of implementation strategies has been prioritized in the most recent program announcement from the NIH, which states that the primary purpose of implementation science is to identify, understand, and develop strategies. Strategies for the adoption, integration, scale up, and sustainability of evidence-based interventions, tools, policies, and guidelines. So our team struggled with the lack of clarity 10 years ago in the literature about what comprises an implementation science. And this was our first effort to map a compilation of strategies. This was based on a literature review. And in what was a pretty arduous literature review because the language was so unformed at that time, we did identify 68 discrete strategies, and we categorized them as planning strategies, education or training strategies. Most of us are involved in professional training. Finance strategies, such as pay for performance, restructure strategies, such as co-locating care, changing roles, moving toward team-based care, managing quality. We're familiar with Plan, Do, Study, Act, and then policy context, such as various rules and regulations. Our team updated our strategy compilation a few years later, engaging experts to vet the original compilation. And this resulted in only slight modifications. We changed the names of some of the categories. We used concept mapping for this, which had the advantage of showing us from people's ratings and clustering of the specific strategies, which of these buckets or category clusters tended to hang together and which were most numerous in terms of the strategies that were identified at the time. The field is moving ahead with some important research on strategies beyond naming them, which was a first necessary step, but insufficient. Now we're learning more about how strategies are effective. And I've been part of a team that has worked in the VA and also in some of my own projects. And we're generally finding that the more strategies, the better. In a study of the VA's initiation of new hepatitis treatment, we found that the sites that used 33 strategies, reported using 33 strategies, were associated through independent data analysis with more initiation of new hepatitis treatment. And similarly, the sites that use the fewest number of strategies were associated with less effectiveness in terms of launching new hepatitis treatment. And yet the situation is complicated because really only 3 of the 15 most frequently endorsed strategies were associated with this. And in some of our more recent results, we're beginning to map the association of these over time. The final principle that I want to mention is evaluating implementation success. And in the framework that I shared at the beginning of the talk, you saw 2 blocks of outcomes. We saw clinical patient outcomes, which are, of course, what we're all headed for, but we saw intermediate outcomes. And intermediate outcomes in implementation science are those things that I mentioned earlier. Is an evidence-based practice acceptable? We're seeing that there's huge variation in our country about the acceptability of social distance, of not traveling. Is it feasible? We've somehow labeled our workers as essential and non-essential, but some of us are fortunate. I'm very, very fortunate that I can be with you virtually. It is feasible for me to to give my intervention virtually. But real world healthcare interventions also vary widely in their feasibility, often in relation to infrastructure and equipment. And are evidence-based interventions sustainable? Maybe we can ramp up and do something for a while, but not sustain it over time. So it's really important that we specifically examine and measure implementation outcomes. Why is this important? This is really important. It's essential for our logic about concluding that implementation is successful, because we could have an effective intervention, and if it is not really adopted widely, has very poor penetration in a health system, or is implemented with poor fidelity or for a short period of time, I'm sorry, we'll go back, then we would not see the clinical outcomes that we expect. And we would be at risk of concluding that the intervention was not effective because we did not see the hypothesized clinical outcomes. But in fact, the intervention might be effective. It never had a chance because it wasn't implemented well. So it's critically important for our logic, for the validity of our conclusions about the effectiveness of interventions, that we focus on these intermediate outcomes and measure implementation outcomes separately and with as much rigor and fidelity as we can. We are learning that fidelity is one of the most frequently measured outcomes. We tend to measure implementation outcomes from survey methods or focus groups, often focusing on provider attitudes. And we're beginning to learn that implementation outcomes are interactive. If we can, and this goes back and actually validates some of the primary principles of Ev Rogers, diffusion of innovation, um, framework or model published decades ago, that if we can persuade someone that something is effective, it's probably going to be more acceptable to them. We also know that in cost constrained environments, a high cost leads to people concluding that adopting this evidence-based intervention is not feasible. Some of the implementation outcomes that we know least about are sustainability. Once we've introduced something, how do we help it sustain over time? When should it be sustained? And scale up and spread. Again, this gets back to the local versus generalizable. If we can implement something here, can we extend the benefits and increase the reach in our populations by scaling this intervention up and delivering it more widely. So I'm going to conclude with some comments about the priority topics for advancing the field. One of the priorities is actually accelerating the translation of research findings to practice. We know that systems are often resistant to change, and there's too much time often lapses between the time of a discovery of an intervention's effectiveness and its widespread delivery for widespread benefit. How do we choose the right research methods to accommodate the complexity of implementation? We have dynamic change processes. We have a myriad of factors associated with implementation. Increasing rigor in measurement remains a challenge. Um, and how do we develop measures that are relevant and feasible given real world settings where most providers don't have time to gather a lot of data about the care delivery processes at the same time they're engaged in delivering them? How do we identify causal mechanisms in implementation to really figure out the processes of all these interrelated changes? And an under-researched aspect of our field is really policy implementation. Now, I mentioned the need to accelerate the speed of our translational processes. So how early should we start implementing? This is a debate that is in our daily news now. Should we start with treatments that have not been subjected to clinical trials? How do we move forward with the uncertainties around effectiveness? Well, implementation science fortunately has some innovative research designs which help us with this, hybrid one-type designs, where we are focused primarily on clinical effectiveness or prevention effectiveness. We can begin to observe and gather implementation outcomes, the response to stakeholders, the fit of these interventions with various contexts. Other emerging approaches to help us move forward include designing for dissemination, shared decision-making, user-centered design, and pragmatic and real-world research designs. This slide illustrates that hybrid studies really bridge the often gap, the time gap between effectiveness studies on intervention and implementation studies on strategies. I've referenced the complexity of implementation science, and I just want to emphasize that again in this brief discussion of challenges and priorities for the field. Context is multi-level, and we have to measure contextual factors. We have multiple types of outcomes, and as I've shown, they are interrelated. We have two kinds of interventions. We have the what intervention and the how. The what intervention being the evidence-based intervention that's being implemented, and the how being the implementation strategy, which by definition is a very complex intervention. And we know that change is rarely linear and that adaptation is typical. So we have to be prepared to capture the what ifs or the improvisation that happens before our very eyes. The sources of data remain a challenge. As I said, we rely often on self-report. We rely some on observation. Archival records can provide some data, but the fact that we don't have procedure codes for many evidence-based psychosocial interventions and that we don't have any procedure codes yet for implementation strategies. So it's very difficult to use records to go back and identify the particular implementation strategies that were employed. And then finally, we have multiple actors. So we have many perspectives on what's happening. Um, I learned this through some pilot data when I asked the same question to a variety of different stakeholders. I was asking what implementation strategies were used. And administrators were reporting that they were using implementation strategies that frontline providers did not acknowledge because it wasn't visible to them. It was behind the scenes. Similarly, providers were doing things to improvise, to educate themselves that may not have been, were often not visible and evident to other stakeholders, such as administrators. So I want to finally close with a few resources for you. I want to encourage you in a path that you might be embarking on toward the D&I field. You certainly can establish your footprint in the field through your research on the evidence-based intervention. Many of you are health services researchers, and the quality gap is a fundamental component of implementation research. Some of you are experts in certain populations, such as older adults or people with particular um, accessibility needs. And the more you know about that population, the better equipped you're going to be for implementation research. And others of you are real experts on a particular setting. And given our focus on context, that's a really important reservoir to bring to implementation science. There are a number of books and journals in the field. Our literature has increased and it continues to increase, which is terrific. In addition to our longstanding premier journal, Implementation Science, we now have a new companion journal, also published by BMC, that is Implementation Science Communication. Both of these are open access, have searchable websites where you can search articles. You can enter a particular condition or a particular provider or a topic within implementation science, and in a matter of seconds have a very robust list of articles that have been published in these journals on those topics. There are a number of training opportunities in implementation science. I've been pleased to lead the Implementation Research Institute, which has set the stage for other trainings funded by NIDA, the VA, National Cancer Institute, NHLBI, NIDDK. And you have a couple of alums from the Implementation Institute or a current fellow, Ronnie Elway and Kathleen Kemp. Wish I could see them in person today, but I'll look forward to seeing Ronnie's presentation later in the program. Want to encourage you to join the national community of D&I researchers by attending the annual conference on the science of dissemination and implementation in health, held each December. We're planning that conference now. We shall see, and we'll keep our fingers crossed, but we'll travel when it's safe. We'll travel when it's feasible. And in the meantime, I wish everyone good health, safety, and lots of learning opportunities. It's been such a pleasure to be with you today. Bye-bye.